والصلاة والسلام بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على رسول الله. Initially, I would like to welcome our international speakers as well our moderators. Also, I would like to welcome all of you, the participants, and as usual, the society is engaged for continuing delivering this scientific activities. And كل عام وانتم بخير، كل سنة وانتم طيبون after the Ramadan and the Eid vacation. Just one or two announcements before we start our webinar. I would like to let you know that you don't need to write your name and your Saudi Council numbers by the chat. So once you registered, that's more enough. In addition, if you are attendance, so you need to register and to attend to earn the CME hours. It will come to you electronically. We will enter it all, and you will notice it by the website of the Saudi Council. The only thing that you need to attend, and those the target audience, they are the one who will receive the CME hours. The other announcement that if you have any question, please write it down at the button of the Q&A, and Dr. Hamad Al-Shaya, he will take care. Okay, thank you very much. I will not delay much. The mic is yours, Dr. Hamad.
Okay, شكرا خالد. السلام عليكم ورحمة الله وبركاته. Good evening, everyone, and it's our pleasure to have you with us in this webinar. I am Hamad Al-Shaya, pediatric nephrologist. I'm going to moderate the session, and on the behalf of Saudi Society of Nephrology and Transplantation, I would like to welcome you all and thank you for joining us tonight. Also, I would like to thank Dr. Khalid Al-Hassan and his group in the society for their tremendous effort to organize scientific meetings over the years. Our topic today, as you know, is on the safety and efficacy of switching to long-acting C5 inhibitor patient with atypical aHUS. Our speaker is very distinguished. He is Professor David Kavanagh. Professor David is a professor of complement and therapeutics at National Renal Complement Therapeutics Center at Royal Victoria Infirmary, Newcastle. Also, he is an honorary consultant nephrologist in Freeman Hospital in the same city. He graduated in medicine and immunology from the University of Glasgow in 1998 and obtained his PhD from Newcastle University in 2006. He was a fellow at Washington University School of Medicine at St. Louis during 2007, and he moved to Newcastle to start his own lab in 2008 after finishing a kidney research fellowship at the University of Edinburgh. In 2009, he was awarded the Renal Association Young Investigator Award for his work defining the role of complement in atypical aHUS. He is the clinical lead for the adult atypical aHUS service and head of atypical aHUS diagnostic service. His group at the university research investigates the role of complement in renal and retinal diseases and is fully integrated with the National Renal Complement Therapeutic Center to provide the rapid translation benefits to patients. It's our pleasure to have you with us, Prof. Kavanagh, and the stage of it.
Well, thanks very much, and it's an honor to be here. Thanks, Dr. Hamad and Dr. Khalid, for the invitation. I'm looking forward to this evening. And as you said, I lead the UK's national programme for the complement-mediated diseases, aHUS and C3G. I'll start with my disclosures. Just to say that we run two national centres, one for C3G, one for aHUS, and we also look after the diagnostics and genetics for the UK for this. Why atypical aHUS in Newcastle? Well, our interest in this stems back to 1974 with this paper from a Newcastle family that first showed that this could be a genetic disease. And this is one of the families that we initially had, and this was Paul Warwick's work in Newcastle, looking at this and 3 other families from Newcastle and around the UK, where we undertook linkage analysis, which showed that the complement system was involved in this, linked to an area of the chromosome 1 called the RCA cluster, and subsequent screening revealed mutations in complement factor H. Now, the alternative pathway of complement evolved to kill bacteria, and because of this, it's a positive feedback loop. The alternative pathway is constitutively active, but can be activated by the classical pathways via antibodies and by the lectin pathway via bacterial sugars. C3b binds to factor B, which is cleaved by factor D to form C3b-BB, which cleaves more C3b, resulting in the amplification loop. Unchecked, this leads to the formation of the anaphylatoxin C3a and C5a, the opsonin C3b, and the membrane attack complex. So evolved to kill bacteria, but it's not great for host cells. And because of that, we've developed a series of complement regulatory proteins, including factor H and factor I. Factor H is the cofactor for the enzyme factor I, which cleaves C3b into the inactive IC3b. And it's these proteins which are disrupted in atypical aHUS. We know that in atypical aHUS, inherited defects in the complement system predispose to disease. Inherited loss of function defects form the majority of cases in the UK. About 27% of all cases of aHUS in the UK are caused by mutations in factor H, membrane cofactor protein, which is the cell-bound equivalent of factor H, about 13%, and then about 6% for factor I. In addition to loss of function mutations, we also have gain of function mutations in the complement component C3, about 11%, and factor B, which are really uncommon. In addition to inherited defects in the complement system, autoantibodies to complement factor H have been reported to cause aHUS, and this accounts for about 5% of all atypical aHUS in the UK. A much higher proportion of those are in children, and in India, the proportion of disease is much higher, about 30%. Although I've said that aHUS is largely a genetic disease, it's not a classical monogenic disease. This is the age of onset of all people in the UK presenting with disease. If they're red, they have a mutation. If they're blue, we haven't yet found one. And what you can see is the oldest person that presented with a mutation was well into their 70s. And overall, you see there are 2 main peaks early in life, in the early childhood years. And we presume that's due to children picking up infections and triggering the underlying defect. And in the childbearing years, and what you see is a large jump here. And if you look at this in men, that kind of bump isn't there. This is exclusively a bump in females, and that's due to pregnancy and potentially oral contraception. Thus, it can be seen that it's atypical aHUS is largely an autosomal dominant condition with variable penetrance. To get atypical aHUS, not only do you require a complement gene mutation, you require a complement gene polymorphism, and even then, you require a trigger. That could be something as simple as a respiratory tract infection or pregnancy. The underlying genetic mutation predicted the outcome of disease prior to the introduction of eculizumab. Those with factor H mutation shown here did worst. It's about 80% going to end-stage renal failure. And those with CD46 mutations did much better, only about 10% going to end-stage renal failure. As well as predicting the outcome of disease, the genetics of aHUS told us a lot about how the biology of the complement system works. The majority of the mutations in factor H were in the C-terminal region. And you can see here that the vast majority are in here. And that told us that what this bit of the protein did. This bit of the protein is about cell surface regulation. This bit of factor H binds to the cell surface, to GAGs and to C3b. And if you look at this, this is C3b in cyan, factor H in dark grey, and factor I in blue. And these red spheres here are the mutations you see in factor H, and these yellow ones are the mutations in C3. And I'll just wait till this comes around, because you can see here there is a groove in the protein down here, and that's where sialic acid sits. And you can see that the mutations here bind to this bit, the C-terminal region of the protein that localizes factor H to the cell surface, binds to C3b, the groove in there to sialic acid, and the mutations here are preventing cell surface localization of factor H. Thus, complement-mediated aHUS is a disorder of cell surface complement dysregulation. The mutations in factor H are in the C-terminus. The autoantibodies to factor H bind to the C-terminal region of the protein, and C3 mutations prevent factor H binding. Likewise, CD46 is a cell surface protein, and this is very much in comparison to C3 glomerulopathy, where mutations in factor H are in a different bit of the protein, and the vast majority of the activity is in the fluid phase. Thus, we know a lot about this bit of the complement system in atypical aHUS, but the downstream effector molecules are less clear. You get a membrane attack complex formed in C5a, and various different pathways have been suggested to result in thrombus formation in the kidney. You get tissue factor release, you get platelet activation, release of platelet microparticles, activation of nets, release of P-selectin, ICAM, 1 Willebrand factor, and ADP being released, and loss of prostaglandins and nitric oxide. And these downstream mechanisms in various combinations result in the thrombus formation you see in atypical aHUS. Now, when eculizumab was first introduced, it wasn't entirely clear that it would work. We know that the mutations we see result in activation of the alternative pathway and great turnover. However, eculizumab acts downstream of that at the level of C5. So when this was initially used, it wasn't clear that eculizumab would have the really transformational effect it did, or indeed if it would turn aHUS into a C3 glomerulopathy type picture. However, it was very effective, and when you look at the outcomes in the pre and post eculizumab era, you can see that the number needed to treat is very low. You only need to treat about 2.5 patients to stop patients going to end-stage renal failure. This is all caused, not necessarily by genotype. So eculizumab was transformational for aHUS, although even now, if you have a mutation in factor H, say 20% of patients will still present too late for the treatment to be effective. So we really do like to screen patients so we know and their relatives, so we can highlight to them that they may present, and if they do, to present quickly so we can treat them. Because if patients present too late, we still can't rescue them. So it's still disappointing that 20% of patients are still presenting too late to be rescued. And those were with mutations. In the UK, we have a kind of centralized system. We are up here in Newcastle, and we get all the referrals. We'll send out a courier, we'll be sent all the details, we'll do all the testing, and within 24 hours, we'll have a decision to treat and lots of the diagnostics back. Now, in the United Kingdom, we are only allowed to treat people that met the initial criteria of the eculizumab trials in aHUS, with the exception of pregnancy. Now, this is how I classify atypical aHUS. You can have the primary TMAs, such as TTP, aHUS with complement gene mutations, and then the slightly rarer ones like DGK epsilon and MMACHC. You've got the autoimmune conditions, such as factor H autoantibodies, and to factor H and to Adams TF13. Infection-associated ones, STEC, pneumococcal, rarely now HIV, and then you've the secondary causes. And if you look at who were actually allowed to be enrolled in the trials, you can see that these are people with known mutations, known secondary causes where there's a high proportion of mutations such as pregnancy or de novo TMA, autoantibodies, and those where you can't find a secondary cause. And this is important when it comes to examining this trials of ravulizumab that we'll discuss later. Not all TMAs were eligible for eculizumab treatment in that initial trial. Clearly, the biggest problem we have is meningococcal sepsis. There's a high morbidity and mortality associated with this, and complement system is critically important in preventing that disease. And eculizumab therefore predisposes to this. And now we spend a lot of time in the UK making sure people are vaccinated, and they have responded. But even then, we still think prophylactic antibiotics are essential. And all our patients get wristbands and cards telling them they need to get in touch if they're unwell. And we still, despite all that, have had 5 cases of meningococcal sepsis. I mean, that's 600-fold higher than the general population in the UK. And we really did a deep dive to see why these patients were getting disease despite all our efforts. And what it transpired is that of the 5 that developed meningococcal sepsis, 4 were not taking their antibiotics at the time, and 1 had a penicillin-resistant strain. So we really do think that antibiotics are essential to stop patients developing meningococcal sepsis despite vaccination. Now, does everybody respond to eculizumab? Well, clearly I'm asking that question, so you probably think the answer to that is no. And here is a 4-year-old boy that was referred from a distant hospital. They had 2 days of vomiting and 1 day of non-bloody diarrhea. They were hypertensive. They had significant proteinuria and hematuria. They were thrombocytopenic. They had MAHA in the blood film. Their creatinine was up and the LDH was 18,000. So all in keeping with atypical aHUS. Now, we started eculizumab and the stool culture came back negative. The stool PCR was negative. Pneumococcal antigen was negative. The plasma homocysteine was said to be normal. That's a story we'll come back to later. And we started eculizumab, and unfortunately, the creatinine didn't start to improve. It actually got worse, and that was despite complete blockade with eculizumab. And then we found there were no mutations in any of the complement proteins, no factor H autoantibodies. So we rapidly exome sequenced this child and found 2 variants in MMACHC, which is part of the cobalamin pathway. And when we did this, we started B12, and you can see the creatinine rapidly starts to fall. And clearly we were not sure these mutations were significant. It looked as if they would be, but we did a fibroblast culture, and it confirmed that these mutations essentially were pathogenic. At that point, we stopped eculizumab, and now all patients referred in the UK will get routine MMACHC sequencing at presentation, regardless of their age. And you can see at that point, we stopped the eculizumab, and the child continue to improve, and the creatinine carries on to improve. So eculizumab does not work for everybody, which is important when we take into account the ravulizumab trials. Now, what is ravulizumab? Well, ravulizumab is an engineered eculizumab molecule, and it takes advantage of the neonatal Fc receptor salvage pathway. Normally, when an antibody is taken up by the Fc receptor, it can be circulated, and if it's not bound to anything, it's recirculated to the cell. If, however, it's bound to, in this case, eculizumab is bound to C5, it is taken up into an acidified endosome and goes down through the late endosome and into a lysosome, and at that point it's broken up. If, however, you can alter that, you can use recycling technology to improve the half-life of ravulizumab. So what happens is when ravulizumab is engineered, it's engineered so that it has a histidine switch, which means that at a lower pH, it will lose affinity for C5, and it will the antibody will recycle to the surface, whereas the C5 will be broken down. And this is essentially the only difference between eculizumab and ravulizumab. So just to highlight that again, what we did was, what Alexion did was they introduced 2 amino acids in this bit of the antibody, and that enhances dissociation in the endosome. It's called a pH switch, and it's dependent on the pH, and in the endosome, the C5 will be released. And they also altered 2 amino acids in the FC region that increases efficiency for FC, the neonatal FC receptor mediated recycling. So we should have a look at the differences. This is C5 in dark gray here, and in this purple color is the eculizumab molecule, and those 2 red spheres are the 2 amino acid differences between eculizumab and ravulizumab. So you can see the binding site is exactly the same. Now, of course, that's important because there is a polymorphism in C5 in this same region, which prevents eculizumab binding. And a very small proportion of UK patients, only two patients in the UK, have this polymorphism that prevents eculizumab binding. However, in Japan, that is 2%. So it's important to note that eculizumab and ravulizumab have the same binding site. And if you have one of these Japanese patients with this, you need to remember that you can't just switch between them. A different complement inhibitor would be required, or plasma exchange. So there have been there's been 1 adult trial and 1 pediatric trial of eculizumab, of ravulizumab, and we'll focus on the adult study first. This is the data, the combined data at both 26 weeks and at last follow-up, a year, and you can see that primary response to ravulizumab at 26 weeks was only 53%. Platelet normalization was about 84%, LDH normalization 76%, and about 60% had an improvement in their creatinine greater than 25%. Really, there wasn't much improvement between 26 weeks and last follow-up, but it was important that if you did have a complete response to ravulizumab at the start, that was maintained throughout that. So if you responded, you did very well thereafter. However, that did look that didn't look wonderful data, especially when you consider that in the trial 3 patients died, and of all the trials with eculizumab in aHUS, nobody had died. So this was a bit of a concern. However, I think it's worth going into this in great detail, because when you look at the patients, it becomes clear that these patients probably didn't have aHUS. The first patient here is 73, and he had a history of diabetes, coronary heart disease, congestive heart failure. He had a stroke, he was encephalopathic, he had respiratory failure, and he was on multiple antibiotics for infection. So he was clearly already infected. On the day he received eculizumab, he was receiving mechanical ventilation and he had Pseudomonas in his chest. Additionally, his CRP and white cell count were elevated prior to the eculizumab. This case very much looks like a septic case rather than atypical aHUS. It's unusual for you to get this sort of chest infection, elevated white cell count CRP in the setting of atypical aHUS. So this didn't look like atypical aHUS, it looked like sepsis. We don't know if there was any genetic analysis on that. No, there was no genetic analysis on this, but you would not expect a 73-year-old presenting with sepsis to have anything to suggest atypical aHUS. If you look at the second case, again, they died of septic shock. Again, a history of diabetes. They had a kidney transplant due to diabetes. So their kidney transplant was not due to atypical aHUS, it was due to diabetes. They had myelofibrosis. So of course, all their bone marrow contents were down, and that had been diagnosed a long time before they presented. And they had recent septic shock. They had acute respiratory distress syndrome. They had multiple infections with pneumocystis and CMV pneumonia. And the patient was on antibiotics when they started. When they received the eculizumab, they were already receiving the ravulizumab, they were already receiving mechanical ventilation. And at day 6, they developed new septic shock with Corynebacteria and Candida and the catheter. And again, the CRP was elevated and the white cell count was actually low due to the cytopenia. So again, we would not feel this with atypical aHUS. This very much looks like sepsis, with the additional complication that they had myelofibrosis. So it's difficult to diagnose whether the low platelet count and the white cell count and the hemoglobin were due to that or the myelofibrosis. So again, doesn't look like atypical aHUS, and perhaps unsurprisingly, there was no pathogenic mutation found. The third patient essentially died of a cerebral hemorrhage. He was admitted with uncontrolled hypertension. He had multiple drugs. Before he was admitted, months beforehand, he already had CKD stage 2. So this was somebody with already profound renal impairment. And when he presented, he progressed to stage 5, he required dialysis. He had thrombocytopenia, anemia, and hypercalcemia. Day 93, had a headache, nausea, vomiting, and developed what looked like a stroke, lost consciousness, and he had a right ventricular hemorrhage. And following surgery, he went to neurosurgery ITU, but the hypertension and loss of consciousness continued, and they withdrew supportive care. So again, this wouldn't be a typical aHUS. This very much looks like CKD with malignant hypertension, and unsurprisingly, he had no pathogenic variant. So these are the patients that we know a lot about because we have a lot of granular data on them from the reporting that was due. I suppose what we don't know is what other patients went into this study and did they truly have atypical aHUS? And that is a concern, because if you look at the patients that stopped dialysis in the initial adult eculizumab trials, 83% stopped dialysis, while in the ravulizumab trial, only 58% stopped dialysis. I think the reason for this becomes clear when you look at the mutation rate in the populations. This here is the proportion of patients in the ravulizumab trial with a mutation or an autoantibody. And you can see it's barely above 20%, whereas in the eculizumab trials, the mutation rate was between 50 and 60%, which is what you see in most characterized cohorts of atypical aHUS patients. So the difference you see between the ravulizumab and eculizumab patients in outcome and death is also reflected in the mutation rate, where the ravulizumab population seems to have a very low mutation rate, much lower than we would expect. Now, if you look at the inclusion-exclusion criteria of the two trials, they are not drastically different. Some of the difference may reflect indication expansion, and some may reflect the national practices in treatment of secondary TMAs. So bone marrow transplant is often treated with eculizumab, and there's not great evidence for its use at the moment. And certainly between the first trial and the second trial, bone marrow transplants could be enrolled into the study if they had were longer than 6 months from starting from the bone marrow transplant. So there was some drift in the inclusion criteria, but clearly in retrospect, we can look back and say there were exclusion criteria that should probably have excluded some of those patients from the trial. One of them was a patient with a confirmed diagnosis of ongoing sepsis. at least 2 of them had that, and a presence of suspicion or active or untreated systemic bacterial infection. Again, 2 of the patients had that. So, you know, certainly some cases in retrospect probably shouldn't have been enrolled. The other thing is some of the entry criteria weren't tight enough. The entry criteria was serum creatinine greater than 97.5 centile for age. Well, clearly the 3rd patient that died presented with advanced CKD, not AKD, and that patient had clearly profound renal impairment before he presented undoubtedly with malignant hypertension. So what I would say about the differences is it's clear that when you look at the granular data we can see in the mutation rates, there were patients in this trial that probably did not have atypical aHUS, which probably explains the differences in death rate and outcome. Now, that's because the differential diagnosis in adults is much more complex than in children. If you look at the pediatric ravulizumab trial, the data becomes much clearer. This is the pediatric ravulizumab and eculizumab data, and actually the ravulizumab data for complete TMA response is better with ravulizumab, and about the same for dialysis at 26 weeks. So when we start looking at the pediatric population, the data looks comparable. And if you look at the mutation rate in the pediatric population, or the factor H autoantibody rate, you can see that again, in a well-characterized population, the pediatric trial has 50-60% mutation positive, while in the adult trial, it was only 20%. And that explains why, you know, there is this difference where the adult trial doesn't look as good as the eculizumab, but we can explain that. And when you start looking at the pediatric population, where the differential diagnosis is much less complex, the mutation rate is kind of where you would expect it to be, and patients are doing better. There has been 2-year kind of follow-up of this now, and both the adult and children have been reported up to about 2 years. There were about 58 in that initial adult trial, 21 in the children that were naive to complement inhibitory therapy, and 10 children switched from eculizumab to ravulizumab. Quite a few of the adult patients have been lost. Of the 58, 2 were initially ineligible because they had STEC, and one of those died. 19 discontinued for various reasons, 3 died. There were 2 that had plasma exchange or plasma therapy. 1 was subsequently seen to have ITP, 1 was DAP positive. And some patients wanted to stop, some physicians wanted to stop, and a few others, I'm not entirely clear what happened to them. And the children, only 2 have discontinued. 1 had a hypertensive crisis, and 1 the physician withdrew. 3 were seen to be ineligible shortly after inclusion. And of the patients that were stable in eculizumab and switched to ravulizumab, everybody continued. Both the adults and the children, if your platelets normalized, your LDH normalized, and all the hematological parameters normalized, then you continued to do well. If you responded, you continued to respond. Likewise, if you had an improvement in your creatinine, you discontinued dialysis. The vast majority of patients either did better or did no worse. And just to summarize that, these are the adults and the children. Perhaps unsurprisingly, what you can see is there was continued improvement in eGFR in those patients that started ravulizumab, and this is probably due to remodeling and resolution of ATN. Clearly, occasionally you had 1 patient that progressed with time. Adverse effects in adults. We've kind of been through the main problems. I think the patients that died undoubtedly did not have atypical aHUS, and they were dying of sepsis or uncontrolled hypertension with bleeds. Meningococcal infections haven't been seen in this trial, but clearly the risk is the same. It does the same as eculizumab, so we would expect ravulizumab to have exactly the same safety profile. And this is in children, again, no deaths, no meningococcal sepsis. What were the side effects? Well, of the initial ones, headache, diarrhea, vomiting is there. Hypertension, whether that's a side effect or a cause of the renal impairment is not clear. But through 2 years, constipation, nasopharyngitis, and fatigue were the ones that emerged new after the initial trial data. In children with longer follow-up, abdominal pain, cough, rash, myalgia, nausea, and confusions evolved, but again, the pyrexia and nasopharyngitis, I mean, most of these, it's questionable whether it's a direct consequence of the medication, but nothing major there. One adult patient who had previously met the complete TMA response while receiving therapy discontinued treatment by choice. The following discontinuation, the patient experienced recurrent disease, his creatinine went up, the patient restarted, and the creatinine improved. So, in summary, in the adult study, complete TMA response was only seen 53.6%. If you compare that to the pediatric study, it was much higher, 78%. And most common side effects, headache, diarrhea, vomiting, nausea, and hypertension. If you look at the adult ravulizumab trial, the trial cohort is clearly different from the eculizumab trial. The mutation rate is much lower in the ravulizumab trial. The initial eculizumab trials were taken in expert centres that already had patients with mutation screening done, and such a pure cohort of complement-mediated adults is unlikely to ever be reflected, and that's probably the difference. The trial differences altered inclusion criteria. Bone marrow transplant was included after 6 months. I think clearly some of the inclusion criteria were, certainly in retrospect, not followed. I think there was probably differences in regional experience of treating TMAs. It's not clear from the paper, but we know that eculizumab is used in different places in different countries. Some patients it's very restrictive, such as the UK, which is still the initial entry criteria. Other places it is used for secondary TMAs much more. And the identifications of secondary TMAs often becomes known only months later, so it's difficult to do this in a trial. The pediatric data, however, is very reassuring. It's a much higher mutation rate, and that's comparable to UK treatment practice. There's a reduced differential diagnosis, and importantly, the outcomes are comparable in the pediatric studies. And with that, I shall stop, and I am happy to take questions.
Thank you very much, Prof. Kavanagh, for this interesting talk. And please write your questions in the Q&A. We have one question. When I can tell eculizumab is effective, for how long I need to continue if no improvement?
Well, that is a very good question. And it's often trial and error. What we would expect is we would normally, the vast majority of patients with complement-mediated aHUS will have a normalization of platelet count within the first week. So it's very quick. The creatinine can take a bit longer. So what we tend to do is we would carry on treatment for at least 3 months while we get the differential diagnosis. And in that time, if we're not seeing a platelet count improve or an LDH improve quickly, we are looking, are we treating the wrong thing? Because it's not immediately apparent. The differential diagnosis, certainly in adults, can be huge. So you're treating while still looking to exclude other causes potentially. Now, if a patient stops passing urine, their platelet count and LDH will normalize anyway, because if you go to end stage, the hemolysis stops. So that becomes more difficult if you have somebody that was hemolyzing that stops passing urine. Clearly they stop perfusing the kidney. The reason for the hemolysis, the mechanical hemolysis, stops, and you don't see that hemolysis. So you have to keep going to up to 3 months, we say, to see is there any improvement in renal outcome. So some of this is you would expect most cases to get better quickly. Some cases will present too late. And we call them non-responders. We call them late presenters rather than non-responders. Non-responders are a group of patients such as DGK epsilon, MMHHC, ENF2, where essentially the phenotype looks like complement-mediated aHUS, but the pathology is different. So if you're seeing somebody that is not responding and is continuing to hemolyze, you should look for other causes. The differential diagnosis is large. We've seen G6PD present with hemolysis and renal impairment and thrombocytopenia. So it can be very difficult. However, the general rule is you would expect platelet count to improve in the first week to 2 weeks if they're responding. Renal function can clearly take a lot longer. We've seen patients that have only started to pee at 3 months. We've carried on because there's been a response, but by 6 months they're off dialysis. But again, it's difficult. If you see continued hemolysis, we'd always be looking for another cause. And we're never entirely sure we've got an atypical aHUS until we have the mutation in autoantibody data back. Otherwise, we are always looking to say, could we have made the wrong diagnosis?
Thank you. There is another question.
Dr. Hamad, can you turn your camera on?
Oh, okay, sure.
So we've I don't know. Will I answer some of these questions or?
Yeah. Go ahead.
So there's a question: is there any role in checking serum MAC level before introducing eculizumab? Well, actually, we've analysed this and we've looked at patients that present with sepsis and SLE and all other different causes that may mimic aHUS. And actually, the serum MAC can be much higher in that than aHUS. It is a serum measure, and actually in aHUS, the complement is at the cell surface. So although in aHUS it can be elevated, it is usually much higher in other things, such as C3G or sepsis. So we don't measure, we do measure it, but we don't base any decision on it because it's not discriminatory for us. It's up, but it's up in a lot of other things too. Now, there has been a story that it's useful in bone marrow transplant. I think the jury is yet out on that, and we need formal studies to look at that.
Okay, there's another question. Yes, Rob.
So,
continue.
Yeah, so there's a question: discontinuation of eculizumab or rabulizumab in children with aHUS who have static CKD4. Is it safe? Well, that's a question. I mean, I suppose one of the first issues is, do we know it's a definitively complement-mediated aHUS? Because one of our questions is, do they have a complement mutation? If they have a complement mutation, about 50% of patients will eventually relapse. And in that case, he's got CKD stage 4. It's borderline. If he relapses, he could go to end stage. But I think the first question for us would be, what's the likelihood of a relapse? Now, we're doing a withdrawal trial where we are looking to see, is it safe to stop in patients and how do we monitor them? And we have excluded patients with a low eGFR because of this. Because if somebody with that degree of kidney impairment relapses, they could end up in dialysis. So for us, I think that's you'd be cautious about that, but really we have found that if you do not have a mutation or an autoantibody, you do not relapse. So it's less likely if they don't have a complement mutation. You might be a bit more relaxed if you could identify what the primary cause was. If it was a factor H mutation, say, I would be reluctant to stop because they could relapse, and if they do, at that sort of renal function, they may well be on dialysis. Okay, I think we've got other questions. I may not be answering in order, so we'll get to them all eventually, I promise. After having a good response in the pediatric group at 26 weeks, what can we predict for long-term treatment duration, or should be initiated at every new episode of MAHA? So I think the question there is, should we stop at 26 weeks? Because clearly in eculizumab, the license for eculizumab was lifelong, and in ravulizumab, it's slightly different. They have tweaked that so that it's actually about 6 months. I think this depends. I think there are trials out there that are, the French group have published theirs. The Dutch and our group are coming. But I think what we'd expect is if you don't have a mutation, you won't relapse. If you do have a mutation, there is a 50% chance you relapse. In the we haven't had anybody that we've stopped out with the trial that has relapsed and hasn't regained renal function when they have relapsed with mutations. In the trial, I don't know the data yet, but certainly it looks safe to stop people without mutations, and it's unlikely they'll relapse. I think what we'll come to is we'll come to a situation where we are withdrawing patients with ravulizumab or eculizumab after the series and monitoring them. And if you monitor them carefully, it's unlikely that they'll come to much harm. That said, in the French withdrawal paper, one patient did go to end stage, but I think they had poor renal function to start with. So it's always a risk, but it's probably the same sort of thing we're doing with ANCA vasculitis treatment. Say we're treating, we're withdrawing, and we're seeing what's happening and monitoring. Okay.
And the other question is, are these two medications are already being participating in the hospital as mainstream of treatment?
So in the United Kingdom, everybody is swapped. We don't use ravulizumab first line. We use eculizumab first line and then switch. And that's because of the half-life. In initial treatment, you might find something where you'd want to stop. About 15% of patients in the UK will be treated with eculizumab and stop after we get a positive STEC result. So not all patients with Shiga-toxin aHUS will develop bloody diarrhea, but 10% don't. And indeed, some of them don't even have diarrhea. So it can be difficult initially to work out what's going on. So in a situation where you did not have bloody diarrhea, we would treat this eculizumab. And then if we got the STEC back, we'd stop. And because of the short half-life, it's not, A, it's cheaper because it's only a single dose, and B, you're not exposing them for as long. Now, the other thing was eculizumab and ravulizumab. Ravulizumab is more difficult to monitor complement blockade. So because of the KD probably, it's coming off in your assay. So it's not as good a monitor of function as you would get with eculizumab. Eculizumab is a higher KD. When it binds C5, it doesn't come off. So ravulizumab, you probably don't want to use in the acute phase because it's more difficult to monitor. So we wouldn't use it then. We would also, but everybody else we would offer to switch to ravulizumab because it's cheaper in the long term if they carry on, and B, it's more convenient for them. And it's, as we've seen from the data, it's probably equivalent. So we would definitely do that. In pregnancy, we would swap back because in pregnancy, ravulizumab, we can't monitor it as well. And with eculizumab, we need to rapidly increase the dose in the second to third trimester because you need a lot more eculizumab. So we can't monitor ravulizumab as well. So in that situation, we'd use eculizumab.
Prof, are you aware of any head-to-head comparative studies ongoing?
No, I don't think we have any head-to-head studies. It was you can see it's difficult enough to do the adult study because that ran in multiple centers for many years, and still they only had a 20% positive mutation rate. So these are very difficult studies to do, and you applaud them for it, but it's unfortunate that there is no direct comparison. Again, the problem, of course, we'll have real life studies where we will treat, and if patients relapse on it, we'll start to wonder. But I don't have much concern looking at, certainly the pediatric data looks very strong. So I don't think our head-to-head will ever be done.
Okay, interesting. Okay, the DJKE mutation usually not responding to eculizumab. Any update on this regard?
Yeah, so certainly the problem with DGK epsilon is it's a relapsing remitting disease. It only really occurs in pediatrics. The eldest person we had was about 8. And what you see is initially patients will get treated because they present with a aHUS-like picture and they may appear to get better, because that's what happens with DGK epsilon. They get better, they relapse, they get better. So they may be treated with eculizumab and then appear to get better. So there is this conception that they got better. However, we've had patients that were on eculizumab and were blocked and have relapsed. And I think there are at least 3 in the literature where a patient on eculizumab has relapsed and they've had DGK epsilon mediated disease. And I think although there aren't many, those 3 cases are really powerful to tell us that it doesn't really work in DGK epsilon mediated disease. And I think we certainly in the United Kingdom, we will stop patients with DGK epsilon when we find it from eculizumab, because we don't think it works. Now they will relapse, but in that situation we don't treat again. And we've had somebody that has relapsed, and what has happened is they have spontaneously got better. And that the natural course of this is over many years. I think in our data set, by about 40, 50 years, about half will have gone to end stage. And it's one of those diseases that is genetic pleiotropism, where essentially DGK epsilon can cause a TMA, but it can also cause an MPGN type picture. And some of that will be a gradual deterioration. But I think, does it work in DGK epsilon? I think the 3 patients that relapsed on treatment would suggest it doesn't.
Nice. Do you prefer to start eculizumab in secondary atypical aHUS?
Yeah, well, we would not treat sepsis with eculizumab. The kind of infection triggered ones tend to be mild viral infections. What we would usually do is we would treat the sepsis first, and normally things get better. It's unusual for us to have sepsis. If somebody's septic, we treat the sepsis, and we wouldn't be treating with eculizumab. It can mimic a TMA, but we wouldn't consider sepsis a secondary TMA. The secondary TMA, such as secondary to glomerular diseases, pneumococcal aHUS, the infection-associated ones, Shiga toxin aHUS, there's no evidence that it works. Clearly, it is a self-limiting disease, and eculizumab has been given for Shiga toxin. However, Shiga toxin aHUS gets better itself anyway, so it's really unclear if it has any effect. And indeed, in the German trial, there is no strong signal from that, where it wasn't really a trial, it was in the German outbreak, they gave eculizumab, and post-hoc analysis hasn't really shown a strong signal. Pneumococcal aHUS, the patients are pretty sick, and the treatment is treating the infection. HIV, again, it's treating the HIV. Then you come down to things like SLE. Now, some places will treat SLE associated TMAs and these other sorts of drug-associated TMAs, malignancy-associated TMAs with eculizumab. Again, there's no great evidence that it works. It is used, but there's no trial data for it. So certainly in the United Kingdom, we are not allowed to use it. And but say in Spain or Germany, there is much more use, but we don't know outcome data yet. So we don't know if that's actually useful.
Do you give loading dose if you switch from eculizumab to ravulizumab?
No, we don't. I think our protocol's on our website. We just give the stand. Well, when I said we don't give loading dose, we just give the standard ravulizumab dosing, and so what we do is we give what they suggest at the 2 weeks. Instead of giving eculizumab at that point, we give the ravulizumab, and we give the ravulizumab dosing. And if you go to our website, we've got a leaflet on how we do this.
So use of eculizumab for FK-induced TMA, duration of therapy after successful re-challenging of medications while using eculizumab. Any need to check point of mutation and inhibitors?
Yes. Use of eculizumab. So I mean, this is this is the secondary TMAs, the de novo TMAs after transplantation. Now, if you check that sort of population, you'll probably get about 20% rare variant positivity. It really depends how good the story is. If you get somebody with a very high TAC level, you stop it and it goes away. And the primary diagnosis was clearly not a TMA, it's unlikely you'll find it. In practice, it's very difficult not to screen these patients if there is any doubt there might be a primary diagnosis of atypical aHUS. So the mutation positivity rate is low, but we do it. And you will find some patients with mutations in de novo post-transplant TMA. Oh.
Okay, which patients' criteria will be optimal to switch from one to another?
Well, I mean, what we've said is anybody can swap unless they are going to get pregnant. Everybody, we don't use it first line in either transplant or acute disease, but they can swap at 3 months. So we don't see any particular barriers to swapping other than potential pregnancy.
Excellent. How much time to be given to see the response of eculizumab before switching to ravulizumab?
Well, I mean, again, that depends. If a patient is treated with eculizumab, responds, you find a mutation, you know you're going to carry on long term, then you can swap immediately once they've responded. So it's if they respond, their renal function is normal, they've stopped hemolyzing, you find a mutation, we don't wait. Normally, the time we'd look at this is about 3 months because you will have all the data by that point. And at 3 months, that's when we plan to swap if we're going to carry on. It's also when we plan to stop if they haven't responded or there might be some other reason why we'd want to stop. So as soon as you find a mutation and they've responded, there's no reason not to swap. But in practice, this usually works out to about 3 months.
Any recommendation change dosage or duration during dialysis?
It's not cleared on dialysis, so it's just standard dosage.
Excellent. Okay, it seems no other questions. I would like to thank you, Prof, for your time and your interesting talk. Thank you very much. Thank you for all of you, and good night. Any comment, Khalid?
Actually, no. Again, I would like to thank Professor David for accepting joining our webinars and delivering wonderful talk. He's, as you know, he's one of the world expert in this field. Thanks also, Hamad, for your excellent moderation of this session. Just a quick announcement that next week we'll have another webinar at the same time, which is about the novel biological therapies for lupus nephritis. It will be delivered by Professor Brad Robin from United States of America. So don't forget to register and join. Thank you very much, and see you next week.
Thank you.
Have a good night.
Thank you very much. Thank you.
Good night, all.
Thanks, David.
Bye. Thank you. Bye.
Good night.
شكرا خالد الله يبارك فيك يا اخي.
يعطيك العافية يا حمد، يعطيك العافية.
شكرا.
Excellent moderation.
الله يكرمك. شكرا. السلام عليكم.